Hello, my name is Dr. Adolfo Martinez Salazar. I am an internal medicine resident at Michigan State University in Sparrow Hospital at East Lansing, Michigan, and I'm here to present a case of arrhythmogenic right ventricular cardiomyopathy associated with Lamin AC gene LMNA mutation. As a matter of introduction, arrhythmogenic right ventricular cardiomyopathy is a medical condition that was first described around 30 years ago as a congenital structural heart disease that consisted of fatty infiltration of the right ventricle. However, now we know that there are actually gene mutations that encode for desmosomal proteins in the nucleus of the cells that are the main triggering event. It is known to be one of the important causes of ventricular arrhythmias and sudden cardiac death, especially in young patients and in athletes. Here we present a rare case of ARVC caused by LMNA gene mutation. Talking about the case, we have a 67-year-old man with a history of hypertension who presented with symptomatic fluttery sensation in his chest and fatigue to his clinic. There was a Holter monitor placed that shows sustained ventricular tachycardia around 200 to 211 beats per minute for around 8 minutes, for which the patient was admitted to the hospital for further workup and evaluation. He had an extensive workup that started with an electrocardiogram that revealed sinus bradycardia with a first-degree heart block and intraventricular conduction delay. And the echocardiogram revealed an ejection fraction of 40 to 45% with basal, inferior, and anterior wall hypokinesis and a reduced right ventricular systolic function. At this point, the patient was started on carvedilol, sacubitril valsartan, and spironolactone. He had a follow-up cardiac catheterization that showed no evidence of coronary artery disease. He eventually had a cardiac MRI that demonstrated some findings suggestive and concerning for ARVC. One of the images that we have here on this slide is showing basal to mid-free wall dyskinesis of the right ventricle. The patient had a right ventricular ejection fraction of 40%, and some images that we're going to see on the next slide showed a dense late gadolinium enhancement that was observed on the basal septal walls. A dual-chamber ICD was placed eventually for secondary prevention of ventricular tachycardia and sudden cardiac death. Genetic panel was ordered as well, and it revealed that the patient had a pathologic mutant LMNA gene. The patient was eventually discharged to an inherited cardiomyopathy clinic and recommended genetic testing for other family members as well. ARVC is a form of inherited cardiomyopathy underlined by fatty myocardial replacement, mostly involving the right ventricular myocardium. It predisposes to ventricular arrhythmias, and this can be explained by a decrease in intraventricular conduction through the fatty tissue and by a microreentry mechanism associated with scar-related injury. Many genes have been identified as potential agents for ARVC. However, our patient was found to have an LMNA gene mutation, which is not one of the most common ones. The diagnosis of this condition includes the presence of symptoms, electrocardiographic findings, and obviously imaging, histopathological, and detection of genetic mutations as well. In our patient, the genetic mutation was detected, and current guidelines currently recommend that first-degree relatives need to be evaluated with a clinical screening with the disease, along with genetic counseling and testing. ARVC is a rare condition that can present with a variety of symptoms, making it a challenging diagnosis and presentation. These patients should have genetic testing not just for LMNA gene, but for all the other potential genetic mutation causes as well. If noted to be positive, family genetic screening should be recommended. Also, preventive measures need to be established to avoid the development of sudden cardiac death, such as an ICD placement. Thank you for your time.